this first presentation in the session will be about pulmonary emphysema. As you know, emphysema is defined as an abnormal permanent enlargement of the air spaces distal to the terminal bronchioles, accompanied by destruction of respiratory tissue and without fibrosis. The important element to remember for this definition is that emphysema is defined in strictly anatomical terms. At that point, there is no physiology, pathophysiology, lung function testing, and so forth. The definition of emphysema is strictly based on anatomy alone. The key concept of pulmonary emphysema is destruction. Like this house has been destroyed by a hurricane, the pulmonary parenchyma will ultimately be destroyed by pulmonary emphysema. How does this destruction occur? The destruction mechanism is based on the activity of neutrophils and macrophages, more precisely on the production of elastase and metalloproteases. There is an imbalance between the release and the inhibition of these factors, and this protease-antiprotease imbalance will eventually act in destroying lung parenchyma. Where and when does this destruction of lung parenchyma occur? Well, a quite recent paper from last year clarified this process and very elegantly showed that narrowing and loss of small conducting airways occurs before the onset of emphysematous lung destruction. So the process first occurs at the level of the small airways and then manifests as emphysema. Why is this important? Because at the time we start seeing emphysema with our imaging methods, the disease may already be quite far advanced. So we learn that emphysema is defined in strictly anatomical terms. It consists in the destruction of alveolar tissue. This is due to a protease-antiprotease imbalance, and the small airways component of the disease occurs before the destruction of lung parenchyma itself occurs. What is the prevalence? As you know, emphysema is part of a group of diseases called chronic obstructive pulmonary disease, COPD. There were about 2 million patients 2 decades ago who suffered from the pure form of the disease in the US. However, it is projected for 2020 that COPD will take the 5th position in the causes of morbidity and the 3rd position in the causes of mortality. So we are likely to see these diseases more and more often. Emphysema is also a very expensive disease. These are data from the European Lung White Book that give you some figure numbers. You can basically almost translate the euro and the dollar numbers one to one. So emphysema is a very expensive disease and accounts for a substantial part of our health budgets. What are the risk factors for emphysema? Well, certainly environmental pollution. There are certain professional groups that are at increased risk of suffering emphysema, coal miners, for example, dentists, technicians, for example. There are some aerosols that have been linked to the occurrence of emphysema. However, the risk factor number 1 is cigarette smoking. So we learn emphysema is a common disease, and emphysema will become even more common and more important in the future. The major risk factor is smoking. There is a multitude of other potential risk factors, many of which are poorly understood at this day. What about imaging emphysema? How do we image emphysema? I would like to put a strong emphasis on CT because the conventional radiograph shows a poor sensitivity in detecting emphysema, especially in the early forms, and MR just does not provide so far the spatial resolution that we require to image emphysema. So when we speak about imaging emphysema today, notably in the clinical context, we speak about CT imaging of pulmonary emphysema. Let me illustrate this with an example. This patient maybe has a little larger lung volumes than usual. But otherwise, there is no flagrant abnormality visible on this chest radiograph. And if you look at the CT of the same patient, you see that basically most of his lung parenchyma in the left lung and in the right apex is destroyed by emphysema, and he would probably not assume this on the basis of the chest radiograph alone. In a clinical context, the imaging of emphysema is relatively straightforward. We need thin sections, meaning 1 to maximum 1.5 millimeter thin sections. We do not require contrast material. We have the patients in full inspiration. We need the patients in full inspiration. And several studies have recently showed that emphysema can be imaged with all various available low-dose techniques. If you image emphysema in a research context, you need to image patients at a constant dose level because you want to compare longitudinal follow-ups of patients. You need to control for lung volume, and the best way to control for lung volume is to use barometrically monitored CT. And there is increasing evidence in the literature that additional scans in expiration might be helpful to image the airway component of COPD, but I'm certain that the later talks will go into this in more detail. What are the radiographic and CT signs of pulmonary emphysema? Distortion and disruption of vascular and bronchial structures, an increase in lung transparency on the chest radiograph, a decrease in lung attenuation, and a focal destruction of lung parenchyma. These are the 4 major radiographic and CT signs for pulmonary emphysema. Because they are so important, again, distortion or disruption of vascular structures, increase in lung transparency, a focal decrease in lung attenuation, and a focal destruction of lung tissue. These are the 4 morphologic hallmarks, the 4 key signs of pulmonary emphysema. I emphasize these 4 signs because notably older literature will present you images like that, where emphysema is linked to a diaphragmatic depression, to an increase of the intercostal spaces, an increase of the retrosternal space, of the retrocardiac space. These signs only occur if emphysema is associated to overinflation. This can be the case, but it must not be the case. And in no way is overinflation typical for pulmonary emphysema. So the so-called classical radiological signs of emphysema, as they were called in the older literature, are in fact the results of overinflation. You might see overinflation in a number of other conditions: chronic bronchitis, asthma, acute asthma attacks, and so forth. So these signs of overinflation may occur with emphysema, but they are in no way typical or pathognomonic for this. So we learned that the imaging of emphysema, especially in a clinical context, is relatively straightforward, and there are 4 radiological signs characterizing emphysema: distortion or disruption of vascular structures, increase in lung transparency, a focal decrease in lung attenuation, and the focal destruction of lung tissue. Let's go to the morphological subtypes of emphysema, and I will briefly go into 3 morphological subtypes of emphysema: centrilobular emphysema, panlobular emphysema, and paraseptal emphysema. Centrilobular emphysema, as shown on this histological slide, is characterized by a very focal pattern of destruction. The lung parenchyma next to these areas of destruction appears relatively normal, and the vascular and bronchial structures are preserved in many of the cases. How does this translate to macropathology? We see these very well-defined holes that look like punched out of the lung parenchyma. And we see the same thing on CT. Typically, these centrilobular emphysema is upper lobe predominant, and we see black holes without borders in these patients. Even if the destruction is quite far advanced, we are still able to recognize in these patients the structure of the secondary pulmonary lobule. And here you have an example of a patient where all the lung parenchyma within the secondary pulmonary lobule is destroyed by emphysema, but we are still able to recognize the basic structure of the secondary pulmonary lobule. The same is true in this patient, and the same is true in this patient who has emphysema in an azygos lobe. We look for the secondary pulmonary lobule and we are able to find this basic anatomical structure. So centrilobular emphysema causes a heterogeneous pattern of destruction because the diseased and the non-diseased areas of the lung create this heterogeneous pattern. The structures of the secondary pulmonary lobule are preserved. The classical manifestation of this type of emphysema occurs in smokers, and the emphysema, or this type of emphysema, tends to show upper lobe predominance. What about the second type, panlobular emphysema? In this type of emphysema, the pattern of destruction is less focal and is much more widespread. There are some bronchial structures visible, but we do not find the structure of the secondary lobule. This leads, as seen here on macropathology, to a much more widespread destruction of the lung parenchyma. And the same is reflected on the CT images. The lung appears as if it would be effaced, if there would be a widespread destruction of the lung parenchyma. And if we look for the secondary pulmonary lobule, we will not be able to find it. Therefore, panlobular emphysema causes a much more homogeneous pattern of destruction than centrilobular emphysema. The structures of the secondary pulmonary lobule are destroyed. This type of emphysema is strongly associated with alpha-1 antitrypsin deficiency, and it can have a diffuse distribution with a slight lower lobe predominance. Several authors consider centrilobular and panlobular emphysema as different entities, and there is some functional evidence that supports this. However, the important thing to remember from a clinical perspective is that you can see centrilobular and panlobular pattern of emphysematous destruction in the same patient. Here a patient with upper lobe predominant centrilobular destruction and panlobular lower lobe predominant elements of destruction. So you can find these two morphological subtypes in the same patient. The third morphological subtype is paraseptal emphysema. This is basically a panlobular form of destruction that is located along the septal and peripheral pleural structures of the lung. Here an example where the peripheral zones of the lung are affected, but there are forms where these areas of destructions are confined to the septal structures within the lung. So the key feature of paraseptal emphysema really is that the pattern of destruction follows the pleural and the septal structures. I would like to very briefly mention one entity that has received a lot of attention over the last years, although it is a rare entity, combined pulmonary fibrosis and emphysema. This entity has been described in patients with subnormal spirometry, severe impairment of gas exchange, the presence of pulmonary hypertension, and most importantly, a poor survival. This is an example of a patient with combined emphysema and fibrosis, emphysema in the upper lungs here in the right upper lobe, and fibrosis mostly of the fibrotic NSIP or UIP type in the lower lobes. And these changes are best illustrated on coronal reconstructions that show us the vertical distribution of the disease with emphysema in the upper lobes and fibrosis in the lower lobes. With any disease, we of course want to know how severe is the disease in the individual patient. And over the last years, there has been a very strong movement towards the objective quantification of pulmonary emphysema. There is a lot of electronic software packages around that perform this tool. Basically, these tools all work similarly. The lung is segmented out of the thorax, if you want, and the attenuation values of the individual pixels are measured, and the results can be displayed in various forms, for example, in form of a histogram. Here a histogram of a normal patient, and here a histogram of a patient with emphysema. What will happen? The histogram will shift to the left simply because the number of low attenuation pixels will increase, and if you want, the numbers will become more negative, more close to pure air. How are the results of these objective quantifications displayed? Here an example. For any given slice, or for any given section, or for any given lung volume, the computer will show you at a certain Hounsfield level threshold how much in percent or in absolute area of the lung parenchyma is affected by emphysema, is destroyed by emphysema. So we learned that there are three types of emphysema, three basic types of emphysema: centrilobular emphysema, panlobular emphysema, paraseptal emphysema. We learned that the different types of emphysema can coexist in the same patient, that there is an entity that is called combined emphysema and fibrosis that carries a bad prognosis, and that we observe an ongoing trend towards the objective quantification of emphysema. What about the radiological differential diagnosis of emphysema? For emphysema, this is relatively straightforward. Theoretically, the differential diagnosis for emphysema includes all focal or diffuse, what we call hyperlucent lung lesions, but in fact, we just have to remember that emphysematous lesions have no walls, and emphysematous lesions are always multiple lesions. There is not one emphysematous lesion. And with this, we can exclude most of the diffuse hyperlucent lesions, and there are basically only two diseases which can be tricky to differentiate versus emphysema, which is advanced lymph angiolyoleiomyomatosis and advanced Langerhans cell histiocytosis. Here an example of a patient with LAM. If you compare this to the patient with advanced emphysema, you see the main difference is that the LAM lesions have clearly defined walls, whereas the emphysema lesions do not have these walls. And the same is true for advanced Langerhans cell histiocytosis, a lot of well-defined cystic spaces with a clearly defined wall, and with emphysema there is no wall. Most of these lesions have no visible wall, and this will help you to make the differentiation between these diseases. What are associated findings to emphysema? This is best explained or understood by just recognizing that emphysema is a smoking-related disease, and in this context, I will only talk about the association with airways disease for sake of time. Why airways disease? Just because we have the morphological information about the airways on the same CT images that we use for assessing pulmonary emphysema. Here a patient with emphysema, and of course on the same image we can see that there are obvious airways abnormalities. We learn that the association between emphysema and airway disease is important. Why is it important? Because emphysema is part of COPD. And COPD has a parenchyma component, which is emphysema. It has an airways component, which is chronic bronchitis mostly, and it has a vasculature component. And we all need to understand how these three components work together and interact to characterize the airflow limitation and the gas exchange abnormalities that are characteristic for COPD. So there are relative contributions of all three of these components, parenchyma, airway, and vasculature, and these will define subtypes of COPD patients. These different components characterize so-called phenotypes of COPD, and imaging plays a key role in defining these phenotypes, in understanding their clinical presentation, and also in allocating them to various treatments. Why is this important? Because emphysema is increasingly recognized as a treatable condition we have smoking cessation, rehabilitation, medication, valve implantation, lung reduction surgery, and lung transplantation. So there are an increasing array of different options for the treatment of patients with emphysema. Early work on phenotyping relied on measuring densities and measuring bronchial dimensions. Now there is a lot of new evidence coming from the so-called COPD gene study that the main thrive of this study is the differentiation and the definition of radiological phenotypes of COPD, and a very, very recent new tool, which are so-called parametric response maps that are obviously able to differentiate the airway and the parenchyma component of COPD in individual patients. What is the perspective of all that? I think we are very steadily moving towards a fully automated analysis of the pulmonary parenchyma and the airways. We also move towards an automated assessment of the fissures, which is important for the treatment of emphysema. And I believe that very soon these tools will be part of our daily clinical routine. Don't forget that imaging has a paramount role in the allocation to treatment, in the outcome assessment, and in the definition of new biomarkers for COPD patients. However, I would like to end with the very practical and clinical perspective and the non-research perspective, and with the perspective of each of us who does not perform research but who sees patients with emphysema and with COPD every day. What should every clinical CT report include? If you have a patient with emphysema, it should state whether there is pure or predominant emphysema in this patient, if your patient has mixed emphysema and airway disease, or if there is pure or predominant airways disease. You should make a statement whether centrilobular or panlobular patterns of emphysema are predominant. You should describe whether emphysema is diffused or localized. Say a sentence about the anatomical distribution, upper low predominant, lower low predominant, diffuse, and make a brief statement about the fissures and the coexisting abnormalities.
So I'm going to talk about smoking-related interstitial lung disease, so a little bit of a kind of a continuation of the theme, but we're going to get down to an even smaller level. So we know cigarette smoking is a leading cause of death in the United States, particularly preventable deaths. And we always think about lung cancer, COPD, and ischemic heart disease as common smoking-related lung diseases. But the link between interstitial lung disease and smoking continues to grow. And we also know that people will smoke no matter what the situation. So even with these diagnoses, it's very hard to get these patients to quit smoking. And for smoking-related interstitial lung disease, cessation of smoking may be the only effective treatment. So this is the proposed classification system for smoking-related interstitial lung diseases. The first group is those that are chronic and that are very likely associated with cigarette smoking. The second group are the acute diseases that are probably precipitated by cigarette smoking in some patients. The third group is diseases such as IPF that are statistically more prevalent in smokers. And then the last category is a particularly interesting one. It's actually interstitial lung diseases that are less prevalent in smokers, and I'll just briefly touch on those. So in my talk, I want to identify the immunologic reactions to cigarette smoke in the lungs. It explains why we see smoking-related interstitial lung disease, describe the histopathology of these diseases, and then show you the HRCT findings as correlation. So when we think about cigarette smoke, there's over 400 toxins in the cigarette smoke that goes into the lung, and the predominant cell that's activated by these toxins is the pulmonary macrophage. This attracts a bunch of other inflammatory cells, releases a bunch of cytokines and other communicating proteins and other substances that causes fibrosis. We've seen some of the effects of that, as well as remodeling of the alveoli and bronchial walls. And then, of course, destruction, as we've seen with emphysema. So we'll talk about group 1, and again, these are the diseases that are highly linked to cigarette smoking. So we're going to talk about respiratory bronchiolitis-associated interstitial lung disease, desquamative interstitial pneumonia, and pulmonary Langerhans cell histiocytosis. So respiratory bronchiolitis is a common incidental finding in cigarette smokers, and if you take a section of lung of any cigarette smoker, you'll pretty much find respiratory bronchiolitis. But it's not a clinical disease, so it's something that pathologists see. So these patients, by definition, are asymptomatic. And again, this is macrophage driven. And we really don't know how common symptomatic disease from respiratory bronchiolitis is, but there is this subset of patients that do develop restrictive lung disease and dyspnea that's characterized by respiratory bronchiolitis. It's usually middle-aged to young adult smokers, and it's just as common in men as it is in women. There have been a few reports of some non-smoking related causes of RBILD, including solder fumes, diesel smoke, and even maybe secondhand smoke, but very, very rare. It's almost exclusively in smokers. And patients, unfortunately, don't have a very good clinical presentation that can help you make the diagnosis. It's like any smoker, they have a chronic cough. They may have mild exertional dyspnea, also very common in smokers, but they may have crackles on exam, which you usually don't see in otherwise healthy or quasi-healthy smokers. And other findings of advanced pulmonary disease, such as clubbing, are uncommon. But these patients do have a respiratory deficit, usually a mild to moderate restrictive abnormality, and their DLCO will be depressed, just only mildly. And what's happening in the lung are these pigmented macrophages are accumulating in and around the respiratory bronchioles and alveolar ducts, but also in the adjacent alveoli. And there's often some mild chronic inflammation characterized by a lymphocytic infiltrate. And there may be some very mild fibrosis. And at least on the pathology, you may see some very mild central lobular emphysema. And this is what you've seen under the microscope here. This is a cluster of pigmented macrophages filling an alveolus here, and this is very characteristic of this condition. So what are we going to see on CT? Well, we're going to see the same correlation. We're going to see these clusters of macrophages that form poorly defined central lobular nodules, and they're central lobular because they're around the respiratory bronchioles, which are located in the central lobular core. You may see some patchy ground glass opacity, and that's reflecting filling of the alveoli with these cells. And because they're smokers, you may see some bronchial wall thickening, but you don't usually see any fibrosis. And here's an example of a patient who was symptomatic, and CT scan shows very poorly defined central lobular ground glass nodules all throughout the lungs. And even here you see some areas of air trapping or hyperlucency, reflecting a small airways component to their smoking-related disease. Here's another example where we see more defined areas of ground glass opacity, and you'll note some very mild emphysema as well in the periphery of the lung. And it tends to have a mid and upper lung predominance, as most inhalational lung diseases do. There's really only one differential diagnosis for that, and that is hypersensitivity pneumonitis. And so the key to distinguishing these two is really the clinical history. Exposures such as agricultural birds and mold for hypersensitivity pneumonitis. And also it turns out that people who smoke are less likely to develop hypersensitivity pneumonitis. So if they're a non-smoker, you're dealing with HP. If it's a smoker, it's probably RBILD. And one of the clues, if you don't have that history, is the presence of emphysema. Prognosis is pretty good. Most patients have mild disease. They may have stable disease if they quit smoking, but some of them will actually progress or not respond at all with smoking cessation. Steroids are ineffective, and there's really no other treatment. But no patient to date has been reported to develop end-stage fibrosis purely from RBILD. DIP is really the same process. It's this very rare condition. It is a misnomer. It was initially thought to be a precursor to usual interstitial pneumonia from sloughed pneumocytes. But now we know these are smoking-related macrophages, and it's just more of the macrophages covering more of the lung. But it has been reported in up to a third of patients with DIP of not being smokers, such as patients with connective tissue disease or drug reaction or other inhalational injuries. So it's not quite clear exactly the pathophysiology, but in the majority of patients you'll see in clinical practice with this condition, they're going to be cigarette smokers. Again, the clinical presentation is very nonspecific, cough, dyspnea, but these patients are going to have more findings such as clubbing and crackles. They're going to have more restrictive physiology, a further decrease in diffusion capacity, and this makes sense because there are more macrophages filling the air spaces in small airways. Again, under the microscope, it can be subject to a sampling error. If you take a small piece of lung, you can miss DIP as a lesion. If the CT shows extensive abnormalities, then the pathologist needs to talk to you about it. Whereas if you sample the right area, you may see a lot of macrophages. There tends to be mild inflammation and also, again, emphysema. Also, it's more of a diffuse process, so if you have larger sections of lung, that's helpful too, even on low power view. But even the pathologists themselves can't always agree on what they're going to call RB versus DIP. So this is, again, where multidisciplinary discussion of these type of cases is very important. So the CT findings correlate exactly with the histopathology. Because there's more macrophages, we're going to see a lot of ground glass opacity, reflecting filling of air spaces and airways displacing normal air. It tends to be more basal and peripheral, and many patients have findings of very mild fibrosis, such as very fine reticular abnormalities. Honeycombing is pretty uncommon. The literature says less than 30%. I would argue it's probably less than 5%. What we're probably seeing in these patients here is superimposed usual interstitial pneumonia. There may be small cysts present, but this may actually reflect emphysema. And then, of course, emphysema is often present in the upper lungs. So this is a patient here with DIP, and we can see a very fine ground glass abnormality. I think you can see it best anteriorly. There's a very fine reticular abnormality, and there's also a bunch of big holes denoted by the yellow arrows here. And this is all emphysema superimposed on this ground glass. Here's another example here where you see a diffuse ground glass opacity in the lung bases, a very fine reticular abnormality denoted by the yellow arrows, and then a few holes in the lung, which could be true cysts, but could also be areas of emphysema, and we even see a little air trapping here in the lingula. So your differential diagnosis for DIP is going to depend, again, mostly on the clinical setting, and that's pneumocystis pneumonia, which is pretty much the only infection that's going to give you a diffuse ground glass abnormality. These are patients who are going to be acutely ill, or if HIV may be more subacutely ill, but they're going to be immune suppressed and have fever and things like that. And then patients with nonspecific interstitial pneumonia, the vast majority will have a connective tissue disease, or this will be a manifestation of a drug reaction. So those are clues to the diagnosis. And the ground glass tends to be more peribronchovascular rather than peripheral in distribution. Prognosis is still pretty good, but again, it can progress if patients continue to smoke, and it has been reported to go on to end-stage fibrosis. Now, the next disease is a whole different pathologic process, and this is pulmonary Langerhans cell histiocytosis, and it falls in this category of diseases called histiocytoses. It used to be called eosinophilic granuloma or histiocytosis X, but this is the current terminology and better describes what we're seeing. So if you recall back to medical school, Langerhans cells are these MHC class II antigen-presenting cells. So they're part of the immune system. They stain for CD1A on their membranes, and so that's how they can be recognized also with their morphology. And what's interesting with this disease is even in adults, up to 15% can have extrathoracic disease. We tend to think of systemic disease more in children who can present with bone lesions and pituitary lesions and liver disease. But in most patients in the adult world, we're going to be dealing predominantly with lung disease. So the vast majority of these patients are smokers. I suspect the 5% that aren't really have the juvenile form. And it has been reported in patients with extensive secondhand smoker, particularly in patients who've had the disease, who've quit smoking, but who are around smokers can redevelop the disease. Again, youngest adults develop this, and the old literature said it was more common in men, but currently there's no sex predilection. Again, very nonspecific clinical presentations, typical of most smokers, cough, dyspnea, but some patients may present with constitutional symptoms such as fever, weight loss. Because they're cysts, they can develop spontaneous pneumothorax. But a third of patients will be asymptomatic, and we frequently will pick this up as an incidental finding on CT. And occasionally they may present with bone pain or pituitary abnormalities if they have extrathoracic disease. The physiologic impairment is variable. Again, it depends on the extent of disease, but most patients will report some limited exercise capacity if they exercise at all, and that's because there may be some vascular involvement, including pulmonary hypertension. But at rest, their pulmonary function tests can occasionally be normal, which can be misleading. So histopathologically, these Langerhans cells accumulate in the lungs, and it starts predominantly in the interstitium of, again, that we're dealing with the small airways, the respiratory bronchioles, which are conducting and gas exchange airways. As the disease progresses, it extends out into the alveolar interstitium and leads to central fibrosis. And then sort of excavation of the central fibrosis can lead to these cystic spaces, which start in the few millimeter range but can become several centimeters in size. And it's thought that this may be secondary to destruction of these small airways or the necrosis in the nodule. So what are we going to see on CT? Well, with early disease, we're going to see centrolobular or at least airway-centric nodules. They generally are sub-centimeter. And if you look very carefully on thin section CT, you may notice a very subtle central lucency. And this is a clue to the diagnosis. These aren't your run-of-the-mill incidental probable non-calcified granuloma that you're going to follow for 2 years. These have little holes. I kind of liken them to Cheerios sometimes. And then if you look carefully elsewhere, you might see a few cysts, and they tend to be very variable, and often as they get larger, they become more irregular. The clue also to this diagnosis is its distribution. It classically involves the mid and upper lungs and spares the costophrenic sulci as well as the anterior tips of the lung. It's almost very rare to even see a cyst in those two areas. So this is a very typical appearance of Langerhans cell histiocytosis. And you'll see the arrows are pointing to these nodules. And you'll notice the tiny little hole within the nodules there. That's the early cavitation. And then I've circled here in yellow an irregular shaped cyst, sort of this bizarre shaped cyst. And this helps distinguish this from other cystic lung diseases. And then you'll see scattered throughout sort of these cystic lesions here with variable degrees of wall thickness here. But overall, they're pretty thin walls. Coronal imaging is very helpful in assessing distribution if you're unsure here, and we can see this clearly has an upper and mid-zone predominant, and the costophrenic sulci are spared, and there's very little disease, if any, maybe a few nodules here at the lung bases. Here's a milder example with just some early nodules noted here in orange, and you see a few small cysts here. Note the bronchial wall thickening associated with cigarette smoking. With advanced disease, it can mimic emphysema as shown earlier here, but again, the presence of perceptible walls in the irregular shape should make you think about Langerhans cell histiocytosis. And again, the distribution is very helpful again in establishing this diagnosis in that it really likes the upper lungs and spares the costophrenic sulci. Now, end-stage Langerhans cell histiocytosis is frequently misdiagnosed as end-stage emphysema. And from a clinical perspective, it probably doesn't matter. This was a patient who went on to lung transplant, and the explant was noted to have Langerhans cell histiocytosis. But often, because they coexist, what's emphysema, what's a cyst can be hard. But I think you can note there's too many lines and sort of walls around these things here just to be all emphysema, which again is just destruction of the lungs, sort of the punched-out appearance. And again, with the distribution, usually in advanced emphysema, you see some emphysema in the bases, and here we have really no disease at the base. And it can progress over time. So here's an example of a patient who presented with disease in 2006, refused to or was unable to quit smoking. And so by 2007, we see the nodules have decreased, and we're seeing more and more cysts. By 2008, again, the nodules are expanding, becoming more cystic. And then by 2009, it's predominantly all cystic lung disease. And this correlates again with progressive airflow obstruction, declining pulmonary function. Now, if patients quit smoking, they might actually get better. About a third will get better, about a third stay the same, and about a third will progress. So here's a patient who had, again, some cysts and some nodules in the upper lungs. You can see, again, the distribution gets milder in the bases. And when the patient quit smoking, about a year later, all the nodules went away. We are left with some cysts, and then again you can see emphysema here as well. So often the cysts usually don't go away, they're sort of permanent, but the nodules will resolve in some patients who cease smoking cigarettes. Now there is a differential diagnosis for PLCH, and the clues to help you make that diagnosis are both the cyst distribution and the cyst morphology. In LAM, the cysts are quite uniform and are uniformly distributed throughout the lungs. LIP, which is usually associated with Sjogren's syndrome and occasionally other immune disorders, they tend to be fewer in number, and they have a basal predominance. Notice this one down here in the costophrenic sulcus. That would be atypical for Langerhans cell histiocytosis. And then, of course, emphysema should have no perceptible walls. And, of course, if you know the patient's a smoker, that's very helpful because it can potentially point you towards LCH or emphysema, and then just look at the morphology. Prognosis is overall pretty good. Survival rates are better than 50%. At 10 years if the patients cease smoking. However, if patients continue to smoke, they will often progress. And there is a subset of patients who progress despite cessation of cigarette smoking. And that may be related to cohabitating with another smoker or being around smokers at work, things like that. Again, with end-stage disease, it mimics end-stage COPD from emphysema or chronic bronchitis, so they may require a lung transplant, and patients with PLCH who develop pulmonary hypertension have a bad prognosis. Okay, so those are the chronic diseases. Group 2 are the acute diseases, and I'm just going to talk briefly about both of these, and this is acute eosinophilic pneumonia and pulmonary hemorrhage syndromes. So acute eosinophilic pneumonia are patients who have this present acutely with fever and acute hypoxia and dyspnea. They're going to generally present to your ED and often undergo CT angiography looking for pulmonary embolism. The exact cause in most patients is unknown, but there is a link to smoking. And there was a nice study in JAMA back in 2004 of 18 U.S. soldiers stationed in the Middle East. All of them were smokers, and they all had eosinophilic lung disease, and 14 of them had just started smoking, suggesting that new onset smoking may be a trigger in susceptible patients. And so in other practice, it's associated with binge smoking. So this is probably as much of a binge smoker as you could possibly see. So it's often also seen in patients who may be occasional smokers. Sometimes you'll see this in college students who will go out on the weekend to a bar and they'll smoke a lot, and they're not regular smokers. And I'll actually show an example of that. So what's going on in the lung? Well, there's diffuse alveolar damage. This is the worst injury to the lung. This is what we see with ARDS. So there's acute inflammation, there's necrosis, it's a neutrophilic-driven process. But in addition to that, there's a lot of eosinophils. And so the diagnosis has to be suspected to establish it. And sometimes you suggest it based on imaging, or sometimes if the patient undergoes a BAL, that's how the diagnosis is made. And to remember is that the serum eosinophilic count is usually normal, but as the disease progresses, it may show up on peripheral blood smears. But these patients are critically ill, and many of them may end up in the ICU, so getting that diagnosis early can be helpful. So what are we going to see on CT? Well, this is an acute lung injury, so we're going to see consolidation, we're going to see ground glass opacity, we're going to see septal thickening from edema. Patients may have small pleural effusion, so it may be mistaken for congestive heart failure, but these patients are acutely ill, they have a fever, and they're generally younger, healthier patients, so it won't fit clinically with just CHF. And the distribution has a slight basal predominance, but overall is not particularly that helpful. So this was an 18-year-old woman who was a college student and decided to go out on New Year's Eve with her friends, started smoking and drinking, and came into our emergency department that night acutely ill. And this was her CT scan. She did not have a pulmonary embolism, but you can see she had some dependent consolidation, a lot of septal lines, looks like congestive heart failure. She's 18, has no known medical history. Was admitted to the ICU, actually required intubation, and they did a bronchoscopy and a BAL, and she had a bunch of eosinophils. And the good news is this responds quite well to steroids, sometimes within hours. And upon getting treatment with steroids, she was out of the ICU within 24 hours, and the disease just goes away. So that's the clue to making this diagnosis. So it's an acute lung injury that doesn't fit with ARDS, it doesn't fit with heart failure or hemorrhage, and you want to think about this. And again, new smokers or binge smokers. Some patients will have a mild deficit after treatment, but the majority of them were back to normal, and relapse is extremely rare. So it's a one-time sort of weird disease, but they probably shouldn't smoke again. What about acute pulmonary hemorrhage? Well, there has been some work done that suggests that cigarette smoking may be a risk factor in patients with Goodpasture syndrome. So in this study from back in '83, published in The Lancet, they had 51 patients with anti-GBM antibodies, and that's glomerular basement membrane. And all the smokers had hemorrhage, but only 20% of the non-smokers developed hemorrhage. And then there was one patient who had resumed smoking and hemorrhaged again. So there may be a link to cigarette smoking. So if you have a patient coming in with, again, acute hypoxia, diffuse lung disease, and hemorrhages on your differential diagnosis, think about that particularly if they're a smoker. Now, group 3 is where cigarette smoking is implicated. It's more common in patients with these diseases, and that's the ones I'm going to talk about are IPF and rheumatoid arthritis. So we do know that cigarette smoking is more common in patients who have IPF, but the exact cause and effect mechanism is not well defined. And there's limited data that show any direct effects. So it may be that cigarette smoking is a cofactor in the development of usual interstitial pneumonia. But what we're going to talk about today, which has been touched on, is combined pulmonary fibrosis and emphysema, because this is a distinct clinical pathologic entity and clearly is linked to cigarette smoking. So these are patients who present with normal spirometry, and if you do an incomplete set of pulmonary function tests, you could potentially miss this, other than the fact your patient is going to be extremely symptomatic. Their diffusion capacity will be markedly depressed because they have both interstitial disease and emphysema, so there's not a lot of normal lung able to participate in gas exchange. They're severely dyspneic, they have a high prevalence of pulmonary hypertension, and their prognosis is far worse than patients with IPF alone, which in and of itself has a horrible prognosis. So these patients don't hang around very long. So it's important when you're reading CT scans of patients with emphysema or fibrosis to make sure you look for the presence of both and report that out, because it helps in sort of prognostic information for the pulmonologist or other clinician to counsel their patient about end of life and things as such, because there really is no effective treatment for these diseases. And here's an example here, and you can see the zonal predominance of emphysema is upper lung. This is large bullous emphysema, but we also see some honeycombing here, and then at the bases there's a far more fibrosis typical of usual interstitial pneumonia. Well, what about rheumatoid arthritis? Well, it's very clear that smoking is a risk factor for developing rheumatoid arthritis. It's also known that patients with rheumatoid arthritis who smoke are at the greatest risk of developing interstitial lung disease. So this is an important bit of clinical history that's helpful in when you're determining whether to CT somebody with rheumatoid arthritis for the presence of ILD. And in this study back in '96, they looked at 336 patients with rheumatoid arthritis, and they found that a greater than 25 pack-year smoking history was a significant risk factor for developing ILD with an odds ratio of 3.76. And so, again, patients with rheumatoid arthritis, you want to look carefully for the presence of emphysema, interstitial lung disease, as well as pulmonary hypertension, which can be a complication of both. It helps in prognostication. No effective treatment for the fibrosis, no treatment for the emphysema. Now, the last group is an interesting group. These are patients that the incidence of these diseases is actually lower in patients who smoke. So cigarette smoking is somewhat protective. And that's hypersensitivity pneumonitis and sarcoidosis. Other ones include Parkinson's disease, but that's not in the chest, so I won't talk about that. But hypersensitivity pneumonitis is an allergic immune-mediated response in the chest, in the lungs, and it both involves the interstitium and the small airways. And there's a host of antigens. The list grows every year. Most commonly, it's birds, agricultural, domestic molds, but there's even non-organic things such as diisocyanates used in industrial paints and some other industrial solvents. Turns out HP is less common in smokers, and it may be that cigarette smoking causes some immune suppression, probably at the level of the pulmonary macrophage, which is involved in type 4 delayed hypersensitivity responses. But it turns out if you're a smoker and you develop HP, you're much likelier to be sicker, you're more and more likely to develop fibrosis, and you're more likely to have recurrent symptoms despite trying to get away from the antigen. So in summary, smokers with respiratory bronchiolitis, it's a biomarker of cigarette smoking. But we know smokers have a whole bunch of other diseases, and there's probably overlap. We see emphysema in patients with interstitial lung disease related to cigarette smoking. There's airway fibrosis. There's alveolar wall fibrosis. So I borrowed this Venn diagram from Dr. Galvin and colleagues from Journal of Thoracic Imaging to show that these can all coexist in the same patient. But I think the take-home point from understanding the pathology of these diseases is that it's really at the level of the pulmonary macrophage that's driving all of these. So this has implications maybe for treatment or prevention in the future, is figuring out these signaling mechanisms to see if we can turn them off, or what is it that's in cigarette smoking that's triggering this, and trying to block that. I do briefly want to talk about sarcoid. It is less common in cigarette smokers. There was one study that showed that smoking is less frequent in sarcoid, but it turns out once you develop sarcoid, cigarette smoking doesn't help. So, cessation doesn't help. So in summary, the link between cigarette smoking and interstitial lung disease is growing stronger. We know it contributes to mortality, and CT is key.
And what we're going to discuss today, it will be small airway disease classification with an emphasis on imaging with CT. So it's best to start with defining a small airway. What is a small airway? These are the airways way down at the distal end of the airway, just adjacent to the alveoli. These are airways with a diameter less than 1 to 2 millimeters. These small airways do not have cartilage in their walls. These are the membranous and respiratory airways only. And from a very practical perspective, this includes airways that are typically beyond the resolution of what we can see with high-resolution imaging. Now, ordinarily, with thin section imaging, we can image out about 8 generations of branching. What this means is maybe a half to 2/3 of the way out of the lungs is where we see airways. And that distal third, distal part of the lung, we typically will not see airways at all. If you look carefully, we see not a single airway out in that distal part of the lung. If we compare that with this minimum intensity projection image of a patient with bronchiectasis and look at that same arc, we can see that some dilated airways in this patient with bronchiectasis. But typically out in that periphery, again, we will not see normal airways. If we look at a patient that has some bronchiolitis, again, looking out in the periphery, this is a normal patient. And out here in the periphery with this patient with these tree and bud opacities, we can see very nicely abnormal small airways. Now, when it comes to small airway diseases, what do you think of first? Some of you may think about air trapping as being the manifestation of small airway diseases. Some of you may also think about tree and bud opacities as the manifestation of small airway disease. Well, in fact, it's both. Let's look at how pathologists classify small airway diseases. This can be a very complicated classification system. Some people have tried to simplify this. Here's a different classification system that made it perhaps somewhat easier to understand. But then we can take this maybe easier classification system, for example, constrictive bronchiolitis, and we can make it complicated again by looking at the different etiologies of these small airway diseases. If we come back to this complicated list, we can simplify this. What is it that these all have in common? They all are bronchiolitis. Now, there's different kinds of bronchiolitis, yes, but in fact, we're looking at these small airway disease and inflamed and fibrotic small airways. So this bronchiolitis is what we're going to talk about. Bronchiolitis is a very generic term. It just means the small airway was insulted. There's inflammation in and around the airways, and it doesn't necessarily have to be an infectious process. Or it may be the residua of that insult. Now, when we image patients with bronchiolitis, we see the bronchiolitis directly in two distinct patterns. We may see the direct result of the insult, or we may see the indirect manifestations of the bronchiolitis and the healing of that bronchiolitis. Or, of course, we may see both, depending upon the chronicity of the disease. And this accounts for the majority of the presentations that we see in clinical practice. This translates to 3 basic CT imaging patterns for small airway diseases, just to make this very practical. We can see direct findings, which is the wall thickening, the ectasia and impaction of the inflammatory debris. This results in well-defined nodules at the small airway level. Sometimes we'll see this as the so-called tree and bud opacities. We may also see ill-defined bronchocentric nodules, which is more the respiratory bronchiolitis pattern, so elegantly described earlier. And we may see the indirect findings. This is the mosaic pattern or the air trapping pattern. These 3 findings, if we relate them back to the histopathologic classification system, will result in a very nice matching between the histopathology and the CT pattern of disease. And we're going to go through these in more detail. I want to emphasize very briefly that there's a greatly added value to multi-detector CT scanning because one of the multiplanar reformatting capabilities, and also for maximum intensity projection imaging, which adds a lot of diagnostic value and confidence for us in distinguishing tubular abnormalities from true nodular disease. So let's review these 3 patterns on CT that we find. The tree and bud pattern. It's exactly what it sounds like descriptively, a tree budding in the springtime. It's a very common observation. Increased utilization of our CT in our clinical patient populations has allowed us to see lots and lots of patients with tree and bud opacities. So it's very important that we keep the clinical context in perspective when we're making diagnoses, because we can see tree and bud opacities as a very common manifestation of bronchiolitis, atypical community-acquired pneumonias, immunocompromised patients, but even simple things like aspiration. So this was a patient came in the emergency room acute with a rule-out PE. There was no pulmonary embolism, but we did in fact see this acute bronchiolitis tree and bud pattern. Here was a patient that had an infectious bronchiolitis. And here I will show you the advantage of MIP imaging. Here we see what looks like some nodules, but when we look at it in the maximum intensity projection, we can see that those nodules now become branching, tubular, ill-defined tree and bud-like opacities, greatly increasing our confidence in making a diagnosis of small airway disease and not a nodular disease like perhaps metastatic disease. Here's another example of a patient with strep pneumonia bronchiolitis. Image on your left is a thin section, ill-defined nodules, but on your right we have greater confidence in seeing the branching tubular nature of this airway disease. Now, it's important for you to remember that not all bronchiolitis is infectious. This is a patient with esophageal cancer who has chronic aspiration and has these basilar predominant tree and bud opacities. Also important for you to remember that not all bronchiolitis is acute. Here's a patient with Cartaginer syndrome, chronic inflammatory small airway disease related to the desmodal cilia syndrome, and we see extensive tree and bud opacities from this chronic airway inflammation. Here's a patient with panbronchiolitis as a result of bronchiolitis obliterans syndrome after lung transplantation. Here's a nice coronal image showing what looks like diffuse nodules, and when we add in the maximum intensity projection, it gives us a very confident diagnosis of extensive chronic tree and bud bronchiolar inflammation. Also remember tuberculosis because, as we all know, the original tree and bud description was first coined by our friends in South Korea in relation to patients with endobronchial tuberculosis. It makes sense. In this particular case, there's upper lobe fibrocavitary disease. If those exudates from the airway get into the airways, they can be aspirated down into other parts of the airway, that endobronchial spread, which also results in this tree and bud bronchiolar infectious inflammatory process. Another patient with tuberculosis. Here we see a cavitary lesion, ill-defined walls in the superior segment of the right lower lobe, and then the spillage into other parts of the lung, suggesting that endobronchial spread of disease. And remember, if we see this in the right clinical patient population, that endobronchial spread of disease is very highly suggestive that the patient is a public health hazard. These are patients that importantly should be isolated and put into respiratory precautions. Now also remember that not all tree and bud opacities that we see are in fact related to the respiratory tree. The vast majority that you will see in your clinical practice are respiratory related or airway related diseases, but we can also see the so-called tree and bud pattern in people that have vascular disease. The MIP imaging helps us distinguish sometimes the respiratory from vascular lesions, because here's a patient with miliary tuberculosis, and the MIP imaging allows us to see that this is more of a nodular disease than a branching tubular airway type disease. And here's a patient with metastatic lung disease, I think it was melanoma, and here you can see extensive pulmonary nodules. The MIP imaging allows us to separate out the tubular branching airway type pattern from someone that has more of a hematogenous vascular tree abnormality. Now the second pattern, ill-defined central lobular nodules, this is what we see in smokers and in people with hypersensitivity pneumonitis, which we've touched on briefly in this session. We can also see this, as was very nicely stated earlier, in other diseases. Now this pattern, it can be very subtle. Many smokers have respiratory bronchiolitis, or in fact all smokers. When we image these patients, we may see some very subtle upper lobe ground glass subtle nodules. It's easier to see these nodules, I think, on coronal imaging because it tends to be bilateral and diffuse and symmetric. So when we're looking in the axial plane, it's sometimes hard to recognize and easier to see in a coronal plane the upper lobe versus lower lobe distribution of these inflammatory lesions in smokers. Now, hypersensitivity pneumonitis, we all know that many of these patients have these occupational or environmental exposures to various things. The most common that we see in our practice is related to birds. Now, the hypersensitivity lesions that we see, they tend to be a photographic negative of central lobular emphysema. Here we can see the typical punched out lesions that were so elegantly described earlier. And we compare that with the hypersensitivity lesion. One is a destruction of alveoli, and one is this inflammatory process at the same central lobular level. So the anatomic distribution is very similar, and they have very similar size and shape and distribution, but they have almost a photographic negative appearance to distinguish the two. Lots of different causes, probably hundreds now known to cause hypersensitivity pneumonitis. These are some of the common ones. People that are exposed to molds in hot tubs, humidifiers, farmers, bird lovers, etc. It gives us a very typical characteristic pattern of these ill-defined central lobular nodules, fairly diffusely in the lungs, but often associated because it's at a small airway level and there's airway narrowing. We often see air trapping, which gives us this pattern of normal lung density, increased lung density, and air trapping and lucent lung density. This has been coined the head cheese sign, where we see these three different lung densities. And this implies there's an inflammatory process at the small airway level. And when we see that head cheese pattern, typically, almost always, it's hypersensitivity pneumonitis. This is a head cheese sign that has been attributed to Dr. Rick Webb, who was a mentor for me and probably some of you in the audience. And this is what head cheese looks like if you've never seen head cheese. Now, the third pattern that we see, the mosaic attenuation pattern, this is an indirect finding of small airway disease. It results from scarring and obliteration of the airway lumen, which results in air trapping. And it gives us these patchy density differences in the lungs. The lucent areas represent the underventilated and underperfused parts of the lung, resulting in that lucency and the mosaic pattern. So, in that original classification system of these small airway diseases, we see these indirect findings in the people with constrictive bronchiolitis. This is the chronic fibrotic type of small airway disease. And we can supplement and increase our confidence in diagnosing small airway disease and constrictive bronchiolitis by looking for the air trapping. We raise our confidence in diagnosing air trapping by using inspiratory and expiratory paired images. On your left is a normal patient inhaling and exhaling. We see a normal increase in lung density. Note how at exhalation there's diffuse, dare I say, ground glass opacity, which is normal when you exhale, and then we use that to find the air trapping. So in general, that mosaic pattern is nonspecific. We can see it in three very distinct and different clinical scenarios. These are the clinical scenarios you see: primary small airway diseases, which make up the vast majority of patients with a mosaic pattern. We also can see it in people with primary pulmonary vascular disease and in patients that have more of an infiltrative disease, such as a patchy multifocal pneumonia. That's why it's so important, because of those three distinct clinical scenarios are so different, why it's so important to take the clinical context into account. Because people with small airway disease have chronic dyspnea, they have wheezing, they have low diffusing capacity, they have obstructive pulmonary function, they don't cough, and there's no fever. And that's a very different clinical scenario from patients with pulmonary vascular disease, where they have dyspnea, yes, but they may have normal pulmonary function. There's no coughing, no response to bronchodilators, and no acute constitutional symptoms. And that's very different, again, different clinical scenario from people who have an acute infiltrate or infectious process. So that implies that we as chest radiologists need to have a dialogue between ourselves and our clinicians. Because when we look at these mosaic patterns, it's all a matter of perspective, and we want to make sure we make the right diagnosis. So when we look at these mosaic patterns, we have to decide which is the normal and which is the abnormal lung. So here is an example. On your left, a patient with pulmonary artery hypertension, and on your right, a patient with mycoplasma pneumonia. They're very, very similar patterns. So how do we tell these two things apart? Well, we have to look very carefully, because in people with airway disease or pulmonary vascular disease, what's causing the lucent lung is decreased perfusion, whereas people with infections don't have that pattern. So we look very carefully at the vessel caliber. And if we look at the vessel caliber in the underlying dense and lucent areas of lung, we can see very distinct differences. We see hyperperfusion and hypoperfusion versus a very symmetric perfusion pattern for people with infectious or infiltrative processes. Here's a patient with Swire-James syndrome. Note the difference in the caliber size of the vessels in the dense lung versus the more lucent lung. When we see this vessel caliber difference in size, we are much more confident that we are dealing with a hypoperfusion, hyperperfusion pattern, meaning that the lucent lung is the abnormal lung and the dense lung is the more normal lung. Another example, a patient with constrictive bronchiolitis, again showing the difference in the vessel caliber size between those lucent and dense areas of lung. We may also find associated bronchiectasis if we see a patchy area, a mosaic pattern like this, and we look and go back. We can see very nicely that these dilated airways, suggesting there's airway disease, are in the lucent areas of lung, and that the denser areas of lung here do not show any of the bronchiectatic airways. And remember, the large airways are connected to the small airways. It's all one airway, and it's a rather arbitrary classification to say one is large and small. They're all connected. It just depends on the level of the insult to the airway and what manifestation we see. So please remember that when we think about air trapping, it may be diffuse, and when it is diffuse, it's very difficult to recognize. Here's a patient with a very extensive small airway disease pattern. If we do an axial section through the upper lungs, we will see that mosaic pattern. But if we do an axial section through the lower lungs, where the air trapping is much more diffuse, it may be rather diffuse and symmetric and not something that jumps out at us. So here's an example of a similar patient with a paraneoplastic autoimmune multi-organ syndrome. In the lower lungs here, there's no mosaic pattern, but he has diffuse air trapping from constrictive bronchiolitis. The coronal section allows us to be more confident about seeing the mosaic pattern. So remember that when we see a patient with a mosaic pattern on CT, we have to keep it in proper clinical context, because the combination of bronchial abnormalities and air trapping on expiratory images are diagnostic of small airway disease. Now, there's often a known cause or association of these patients with constrictive bronchiolitis, so that there may be a known working diagnosis, but it does help us determine the extent of their underlying lung disease. We talked about these 5 histopathologic entities that manifest in these 3 CT patterns of tree and bud opacities, ill-defined nodules, and air trapping. As another way of representing this is a sort of a Venn diagram presentation. These small airway diseases may have an acute inflammatory bronchiolitis pattern. Sometimes it's a chronic bronchiolitis pattern that results in tree and bud, but also it can result in these ill-defined nodules that we see in hypersensitivity or in smokers. And then there's the indirect findings with air trapping and the mosaic pattern.